This is associated with a deterioration in his breathlessness. However, he remains mobile and independent. So the question is, which one of the following antibiotics would be most suitable as a first-line treatment? Now, look at the 5 options. You have a minute or so to make your mind up, and then we shall discuss them. Alright, so if you chose oral ciprofloxacin, you chose the right answer, the others are incorrect. And just to elucidate this further, I shall discuss antibiotic therapy of bronchiectasis in general. So, as with any infective condition of the chest, before you start antibiotics, if the patient is producing sputum, you should try and send a sample. This is particularly important in bronchiectasis because patients who grow one organism may actually grow it repeatedly. So it's quite good to have previous cultures. The other important thing to remember about bronchiectasis is that it can be quite difficult to eradicate the organism. So all treatment regimens that I'm going to refer to in these slides should be for 14 days and no less. So if you have a patient with bronchiectasis and you don't have any previous microbiology results on them, and they come in with an exacerbation, you should be giving them amoxicillin 500 milligrams 3 times a day for 14 days, as mentioned previously. The commonest organism in bronchiectasis is actually Haemophilus influenzae, and patients who grow Haemophilus repeatedly may need a higher amoxicillin dose, particularly if they're proving hard to eradicate. So 1 gram TDS, for example, or sometimes 3 grams BD, again for 14 days. However, our patient in question grew Pseudomonas aeruginosa in their sputum, and the approach to treatment of this organism isn't that straightforward. So your first line treatment is ciprofloxacin orally, 500 milligrams twice a day for 14 days. However, your patient may be very unwell, or they might have failed treatment with Pseudomonas, in which case you can give them intravenous therapy. And you can use any one of ceftazidime, tazocin, meropenem, or astrionum. However, if your organism is resistant to one of the above IV antibiotics, then you combine another one of them, which the organism isn't resistant to, with an aminoglycoside, such as gentamicin or tobramycin. Now, Pseudomonas is associated with a deterioration in bronchiectasis and deterioration in lung function. So if your patient grows it, it is worthwhile giving them a trial of eradication. And this is typically done with ciprofloxacin 750 milligrams twice a day orally for 14 days. That's first-line eradication therapy. However, should that fail, then there are various other options, including 2 weeks of intravenous antibiotics with or without nebulized colistin. Just before I finish off on this question, I wanted to go back to some of the options and discuss why they might not be appropriate. So obviously, ciprofloxacin was the right answer. Pseudomonas is almost universally resistant to amoxicillin, so that's not appropriate. For this patient, IV ceftazidime and gentamicin isn't appropriate first-line therapy because they don't seem that unwell, and if they were that unwell, then combination therapy would not be first-line. You would just give them IV ceftazidime. IV colistin is an extremely toxic drug and should only be reserved for resistant cases where other treatments have failed. Nebulized colistin isn't an appropriate treatment for someone who has an acute exacerbation of bronchiectasis. Rather, it's maintenance therapy for patients who repeatedly grow Pseudomonas. Question 2. A 70-year-old female smoker presents with a 3-day history of loss of sensation of both her lower legs. She also reports a 1 stone weight loss and unresolving cough over the last month. Her chest X-ray shows a large hilar mass, not seen on a chest X-ray from 2 months ago. She has no other past medical history and is not on any medication. On examination, she has loss of light touch and pain sensation in a stocking distribution, reduced air entry in her right chest, palpable supraclavicular lymph nodes, and a large craggy liver edge. She has a normal full blood count and differential. So the question is, which one of the following is the most likely diagnosis? I'll give you some time to look at those. So the correct answer here is small cell carcinoma of the lung. In a smoker with such a rapid onset of an abnormal chest X-ray and the other clinical features mentioned, small cell carcinoma is the most likely diagnosis. If this were to be non-Hodgkin's lymphoma, then with such a rapid progression of lymphoma, you would expect an abnormal full blood count because of marrow involvement, but obviously that is not the case in this patient. Adenocarcinoma and squamous cell carcinoma of the lung are a lot more slow growing, so it would be very surprising for someone to go from a completely normal to an abnormal chest X-ray in such a short space of time in anything but small cell lung cancer. Sarcoidosis can cause hilar lymphadenopathy. In fact, it's quite a common presentation of that. But if you were to find hepatomegaly in sarcoidosis, it would be smooth, not hard and craggy. So I'm just going to talk through the clinical features of small cell carcinoma of the lung. So as we've already mentioned, it can progress very rapidly. Usually, the mass in this kind of cancer is central. So you get the abnormalities in the hilar area on the chest X-ray. Hyponatremia is a common feature of this condition due to the syndrome of inappropriate ADH secretion by the tumor. Brain metastases are a common feature, often quite early. And again, because of the central nature of the tumor, superior vena cava obstruction is quite common. As the tumor can often secrete ACTH, ectopic Cushing syndrome can be a presenting feature. Another paraneoplastic syndrome in small cell carcinoma is the Lambert-Eaton myasthenic syndrome, which is similar to myasthenia gravis in that you get proximal muscle weakness with areflexia, ptosis, and diplopia. However, the difference is that initially on stimulation, you can actually increase the strength of the reflexes, as opposed to with myasthenia gravis where you can't do that. Question 3. A patient comes to your clinic after his overnight oximetry which shows repeated desaturations consistent with the diagnosis of moderate to severe obstructive sleep apnea. He is finding it difficult even to go to work, owing to his daytime sleepiness. The question is, which one of the following would you advise to him as the best treatment? I'll give you a few seconds to look at the options and choose the answer. So if you chose option A, continuous positive airways pressure or CPAP, that was the correct answer. In fact, that is the only appropriate treatment for people who have excessive daytime somnolence due to obstructive sleep apnea. As far as modafinil is concerned, it isn't really a treatment for OSA. It's used more for conditions like narcolepsy. It can sometimes be used in OSA in patients who are already on CPAP, but despite optimal CPAP, the sleepiness hasn't really improved to the degree you'd like. There is really no place for long-term oxygen therapy in the treatment of OSA. Nocturnal lorazepam would just make things worse. Mandibular advancement devices tend to be treatments for snoring rather than sleep apnea. However, they can be used in very mild obstructive sleep apnea, where they can improve the snoring, but often have no effect on the sleepiness. And this tends to be people who can't tolerate CPAP generally. So this slide just very briefly explains the pathophysiology of obstructive sleep apnea. On the left-hand side, you've got a normal airway, which remains unobstructed all night. However, in a patient with obstructive sleep apnea, when they sleep, all the muscles in their body relax, and the muscles in the throat relax as well. And these muscles have the job of keeping the upper airway open. but when the muscles relax, the upper airway can actually obstruct, and this obstruction happens at the level of the soft palate. As a result of this, air does not pass through beyond the area of the soft palate, and the patient desaturates. This obviously sends an impulse to the brain for the patient to wake up. Then the patient wakes up, breathing is restored, and then the patient falls asleep again. And this could be happening several times an hour without the patient even realizing it. And as a result of this continued cycle of waking up and falling asleep repeatedly, when the patient wakes up the next day, even though they feel like they have slept, they haven't actually. And as a result of that, they repeatedly fall asleep in the daytime. What you can see on the screen is an overnight oximetry trace, overnight oximetry being a common screening test for obstructive sleep apnea. On the x-axis you have time in minutes. Each trace represents 1 hour. And what you're looking at is the desaturations that you experience overnight. So at the beginning, the patient is awake, so the saturations, which are being measured on a scale of 70 to 100, are in the range of about 90, which is normal. When the patient falls asleep, he starts desaturating because of the upper airway closure. So each time the upper airway closes, the saturations drop. Then when the patient wakes up, the upper airway opens up, the saturations return back to baseline. And this cycle keeps repeating and repeating, which is why you get this jagged sawtooth type appearance of the trace, very typical of obstructive sleep apnea. And that's just a picture of the treatment, continuous positive airways pressure, or CPAP, which is delivered by a tight-fitting mask worn over the nose, sometimes over the nose and mouth, and sometimes by more sort of non-invasive measures, such as nasal pillows inserted straight into the nostrils. And it used to be that people didn't like CPAP because it was very noisy. However, newer machines are actually very, very quiet and less disruptive to the partner. Question 4. A 55-year-old man presents to the emergency admission unit with a dry cough and shortness of breath, which he has had for the past 4 days. He also complains of some abdominal discomfort, nausea, vomiting, diarrhea, and a headache. He was previously well before he developed these symptoms and is not on any medication. On examination, he is unwell with a blood pressure of 123/67, pulse of 92, and a respiratory rate of 22 per minute. On auscultation of his chest, he has bibasal crackles. His cardiovascular examination is unremarkable. These are his blood investigations. I'm not going to read out all of them, but you can see that he has a raised white cell count. He's hyponatremic. He's got a borderline raised urea, an elevated CRP, raised bilirubin, and some evidence of derangement of the liver enzymes. So the question here is, which one of the following investigations is most likely to be helpful in elucidating the diagnosis? So you've got 5 options from A to E. I'll give you some time to think about them and choose the right answer. The correct answer is E, urinary antigen testing. You would be testing for Legionella pneumophila, which is the organism causing this man's disease. This patient has all the hallmarks of Legionella pneumonia, also known as Legionnaire's disease. So, contrary to popular belief, Legionella pneumonia occurs usually sporadically as isolated cases rather than in outbreaks, although it was first described in an outbreak. Interestingly, there's a striking male preponderance. Twice as many men get Legionella as women, and they tend to be middle-aged. The strong risk factors for this condition are smoking, use of whirlpool spas, living close to a cooling tower, recent plumbing repairs, consuming untreated water, and also there's a not so strong link to use of air conditioning. Features of this disease: a cough which may be dry actually, productive of no sputum at all. Interestingly enough, constitutional symptoms such as headache and feeling generally unwell can be very prominent. Often the disease can be mistaken for a gastroenteritis because patients can have abdominal pain, diarrhea, and vomiting. On blood tests, interestingly, hyponatremia and derangement of the liver enzymes is commonly found. The best initial test for this condition is, as we mentioned before, the urinary antigen for the organism. In terms of treatment, first-line antibiotics for this condition are fluoroquinolones or macrolides, which may have to be given for a period up to 14 days. Second-line therapy is with tetracycline antibiotics. The last question in this lecture, question 5. A 27-year-old pregnant lady is referred to the emergency admission unit for sudden development of shortness of breath. She has some left-sided chest pains but no cough or hemoptysis. She is 28 weeks pregnant and has had no problems with the pregnancy. There is no history of long flights or swelling of her legs. On examination, she appears anxious, with a blood pressure of 110/60 millimeters of mercury, a pulse rate of 92 and a respiratory rate of 26. Her oxygen saturation on air is 98%. Her abdomen is distended and fetal movements are seen. Her chest is clinically clear. Her cardiovascular and lower limb examinations are unremarkable. These are some blood test results, so I'm not going to go through them all individually, but you can notice that she's borderline anemic, which would be within physiological limits for a pregnant woman. Her chest X-ray is unremarkable. Her D-dimer, however, is elevated at 0.62, the upper limit on this assay being 0.25. The question here is, which one of the following investigations would be the most appropriate initial investigation in her case? I'll give you some time to look at the options. So the correct answer for this case is bilateral leg Dopplers. I'm going to take you through the assessment and investigation of a patient with pulmonary embolism. So first of all, before embarking on any investigation in a patient with suspected PE, you need to do a probability scoring. And an easy way of doing this is by calculating the modified Wells score. So you score a certain number of points for each of the following points: clinically suspected DVT, alternative diagnosis less likely than PE, tachycardia of more than 100, immobilization or surgery in the previous 4 weeks, previous history of DVT or PE, hemoptysis, treatment for malignancy within the last 6 months, or a patient with malignancy who is palliative. And then you divide the patients into 2 groups. Patients with a score of more than 4, you classify as likely to have PE, and you go straight on to diagnostic imaging. You do not do a D-dimer in these patients. Patients with a score of 4 or less are classified as unlikely to have PE, although it is still possible. So in those patients, you would consider doing a D-dimer, and if the D-dimer is negative, then in this group of unlikely PE patients, it's quite a good test to rule out PE, and no further investigation is needed. However, should the D-dimer be positive in this group, you do need to do further imaging. In the case of our patient scores a 3, based on the fact that there is no other alternative diagnosis to explain her symptoms, so she falls into the PE unlikely category. However, because her D-dimer was raised, we do need to investigate further with imaging to exclude the diagnosis. It's worthwhile remembering that the classical patient with PE described in textbooks with hypotension, tachycardia, shortness of breath, chest pain, hemoptysis, and an abnormal ECG and swollen legs is actually quite unusual, and many patients may have just one symptom. And in these cases, it's about keeping a high index of suspicion and making sure that there's no alternative diagnosis, and if not, then moving on to investigate for PE because it is a very commonly missed diagnosis. It's worthwhile pointing out here that the D-dimer is often elevated in pregnancy anyway. However, if it's negative and the patient clinically is unlikely to have a PE based on probability scoring, it is quite useful. So our patient needs imaging in view of the fact that she's got a positive D-dimer. If imaging is required, then bilateral leg Dopplers are first line because there is no radiation involved. And then again, if you remember, our patient didn't actually have any leg swelling or pain. However, nearly half of patients with a DVT will have no clinical features of it. So it's worthwhile bearing that in mind. If the Doppler is negative, it could just be that the clot has migrated to the lungs and you can't see it in the legs anymore. And really what you do from then on depends on what your local radiology protocols are. And different places will use either a CTPA or a VQ scan. A CTPA gives a radiation dose of 3 to 130 micrograys to the fetus. And it would make sense that this radiation dose increases with advancing pregnancy as the fetus approaches the chest, which is the area that gets irradiated. With a CT pulmonary angiogram, there is also a risk of irradiating the maternal breasts. A VQ scan again delivers a considerable radiation dose between 100 and 170 micrograys. Some departments do a half-dose VQ scan, and often if the X-ray is completely normal, they will do just a Q scan, so that would be just the perfusion element and not the ventilation one. I just wanted to go back to the options to talk about them. Arterial blood gas would not be helpful. You expect it to be normal in this patient. She has normal saturations. Ventilation perfusion scan, for the reasons we've discussed, is probably not the best first-line investigation. A pulmonary angiography, again, is a very invasive test involving injection of dye. Although it is the gold standard, it's very rarely done. An echocardiogram may be useful in an emergency situation when you're suspecting PE and the patient's collapsed and hypotensive. If you do an echocardiogram, you may see right ventricular strain and paradoxical motion of the intraventricular wall, which may help you quickly make a presumptive diagnosis if you're considering thrombolysis.